I'm very happy that Sri Arun Singh, Advisor, Health, Government of India, and who is also discharging responsibilities as Dean of All India Institute of Medical Sciences, Jodhpur, is interacting with us today on the specific manner in which he himself has treated him for COVID. Sri Arun Singh is a distinguished medical professional hailing from West Bengal Health Service, who spent long years in both research, teaching, and in evolving various national programs, including RBSK. In the last 10 to 12 years, Dr. Arun Singh has been leading the child care programs from the medical point of view, and he has been recognized as the father of all mental development and child care programs in the entire country. Dr. Arun Singh has also been associated with a program called Samarpan in Madhya Pradesh, which aimed at the mental development of children at a very young age. I'm very happy to welcome Dr. Arun Singh, and we would have an interaction with him relating to the manner in which the COVID treatment can be looked at it from slightly different perspectives. Over to Sri Arun Singh.
Dr. Arun Singh, and I'm a professor of neonatology at AIIMS Jodhpur, including I'm a national advisor to child health program with Government of India. My apology because last night, I've just recovered from COVID. Last night I made the slides and somehow it disappeared. So very quickly I had to remake from whatever memory I had. So I would be talking today, seeing COVID not only as a researcher, not only as a doctor, but also as someone who spent almost 3 weeks in an ICU care in COVID at AIIMS Jodhpur. And what were my understanding, what were my reports, and how did it change my perception? So the aim of this presentation is not to confuse you, is not to tell you something, but just a viewpoint from a patient, a doctor, and a researcher all merged into three. So we know of the COVID universe, and we know the case fatality rate depends upon death and detection. So supposing I had to do this study in Hyderabad, and over the last 7 months, say from February to October, repeatedly I tested everyone in Hyderabad, irrespective of the symptoms, because remember, a lot of us are asymptomatic. And if that was the detection, then the death rate would be the actual case fatality rate. Neither globally nor India has the actual case fatality rate, because for that you'll have to do a different experiment where the universe is everyone from birth to whatever age you can think of, the entire population of this country. If you are screening them repeatedly, then only you could get the correct denominator of how many were detected positive, and then the death would tell you. So, is it possible that there's some experiment where this experiment has been done? So it was not by design. And I'll come to this again and again. But as early as 3rd of February, 3,711 passengers, Majority of them was 70 years plus, because at that time you think you have earned enough, now you want to see the world. So they were all in this cruise ship. And as the ship went to Singapore, some of the people felt feverish, and since they were old age, they wanted to get down, and they got admitted and they were tested positive. This message created a panic, created a coronaphobia. And the next destination was Japan, and Japan didn't allow the ship to come in. For almost more than a month, 3,711 passengers, think of it, apart from the crew members. And they consisted of people across this country. 50% had underlying disease. Average age was 70 years. What were their feelings? They were enjoying, they were mixing. They knew that about 700 people were ill, including one nurse. But what to do? They had to stay there. Some of them thought, in their interview, they said, all of us will die one by one. This COVID will take away. But did it happen? Now, here is a classical case where after 1 month, each and every individual, that's the universe, 3,711, everyone was done repeated COVID testing, repeated. And everyone was tracked with what comorbidities and how many died. All of you would be surprised that from February, this is October, the death rate when the universal screening of each and every one, the death rate was 0.35%. I can vouch as a doctor that there's so many diseases in our country which would have a mortality rate of 1 or 2%. Why was COVID so singular? I remember reading this again and again, but not understanding the physiology. How come 3,712 persons and only 13 deaths? There's something wrong. They were all mixing up. The crew was there. How could it have happened? And there were only two answers at that time. Are we unnecessarily fearing? And let me be honest with you. I read this again and again, but couldn't explain it. So when people said 3-layer mask, people said lockdown, I accepted it. Remember, this is 3rd of February. But strangely, India's death is much lower than the world's death. And I'll come to it why. But please remember, John Snow, he could say it is water. He couldn't identify the etiological agent for cholera. But by seeing the study, by seeing the flow, he understood by mapping out that it must be water. And how correct. Sometimes you may not even identify the virus, but if you see this kind of an experiment, which cannot be done ethically, you can't keep so many people with COVID positive all together in one place. But this was done. Now, was this COVID something new? So I was very keen about it. And I got this paper, which I would like to share with all of you. It talks about SARS. In layman terms, it is severe acute respiratory distress. It happened in 2002, what we now call it SARS-CoV-1, and it happened in China only. And this paper was published by two Italians, K. Stadler and R. Rapolo. He writes, in late 2002, a new disease, a severe atypical respiratory distress, has emerged in China. This was an unknown animal coronavirus because all of you know that it was initially in bat and it jumped to human, that has crossed the species barrier through close contact of humans with infected animals. It rapidly adapted to the new host and not only became readily transmitted, transmissible between humans, but also pathogenic. Remember, this paper has been written in 2005. Air travel spread it around the world, and ultimately the virus infected 8,096 people, caused 774 deaths in 26 countries on 5 continents. Aggressive quarantine measures, he said, people think that it is successful in terminating the disease. And he says currently there are no SARS cases. Most likely virus no longer circulates in the human population. But the last few lines which he wrote was very, very important. Remember, this is happening next door. And what was the SARS-CoV-1? It was characterized by flu-like symptoms, including high fever, malaise, cough, diarrhea, and a whiteout on the chest X-ray. The overall mortality was about 10%, but varied profoundly with age. People with older age got infected, children were not infected, and the course of disease seemed to be milder in pediatric age group and resulted rarely in a fatal outcome. Mortality in elderly was as high as 50%. After reading this paper, I reminded myself, you don't need to be a doctor. There is a philosophy much bigger than the medical science, that's the philosophy of nature. And it tells you, when once neighbor's house is on fire, you too are in danger. And that's the Spanish nam tuae es agitude, paris cum proximus adeit. Perhaps when this was happening in 2002, published in 2005, we should have started looking at it the whole world. Incidentally, there were 3 people from India, and they were younger age. This is all the data of 2002. All of them had very similar symptoms to SARS-CoV-1, and that is why this virus is now known as SARS-CoV-2 because of its resemblance to genomic virus. It's a big virus, and it varies quite a lot. But clinically, 2 things are very common. The spike protein, which helps it to get the receptors on the cell, what we call the ACE2 receptors. And the ACE2 receptors, for it to get activated, you require the TMPRSS gene, which incidentally increases in cancer, especially in prostate cancer. Without the TMPRSS2 gene, which is within the cell, so I always call it learning philosophy from Ramayana. Lord Ram could not have won over Lanka unless and until we had a Vibhishan. So the TMPRSS2 is the Vibhishan within the cell, which comes out, helps the COVID virus. So its spike protein cleaves it at S1 and S2 and says, now you can enter nicely. Why does it do so? I'm not a cellular biologist. I would not be able to answer. But yes, it is very, very interesting. The hospital staff were wearing masks. Aerosol procedures was increasing. Pre-existing illness like diabetes mellitus and heart diseases contributed to intensive care. Remember, this is not CoV-2. I'm talking of CoV-1. The main feature was fever, then chill and fever, myalgia, malaise, cough, dyspnea, whiteout lung. And the characteristic on the HRCT was there was a ground glass opacity. And SARS-CoV was using the angiotensin converting enzyme 2, ACE2, as the cellular entry point. And we found that there was thrombocytopenia, leukopenia, in particular lymphopenia. Now, for general people, we have in our blood 2 things: the white fluid in which the RBCs are suspended, is the plasma, and the cells which are suspended contains the RBC, which actually contains the hemoglobin, which attaches to oxygen. So the lymphocytes, peculiarly both in SARS-CoV-1 and CoV-2, which are very essential for fighting the virus, suddenly decreases, and this we call lymphopenia. Lymphocytes, penia means less, they become less, and LDH becomes less. And some of them were also having elevated SGOPT and elevated CPK. Systemic steroids was found to be very useful, uh, and this was a very interesting comment as early as in 2002, and they found that the serum cortisol levels were actually um, um, the IL-6, the IL-8, IL-16, TNF alpha, they were very high, and they were creating a very progressive pulmonary inflammatory load. And they suggested as early as 2002, which was again published in 2005, that this was a cytokine dysregulation. In fact, they found that if you give a pulse high-dose steroid treatment, it was useful. At that time also there is the lopinavir or the ritonavir and the plasma therapy. So please understand, even before 15 years back, all this was tried, and if you take 2002, it is 18 years back. And it also showed at that time that lopinavir and ritonavir as a rescue therapy did not lower the death rate. All this was known long back. And I repeat what Karl Marx said, history repeats itself first as a tragedy and second as a farce. And in 2015, an article came out as a Nature, but it was not a letter. It was a huge article. And this was, there were 15 American scientists from some of the most top-ranking American universities and only 2 Chinese. And this was funded by so you had North Carolina, you had Harvard Medical School, you had people from Switzerland, you had the North Carolina, the Department of Epidemiology, National Center for Toxicology from Arkansas, and some of you must be having looking, cystic fibrosis from Chapel, from Zurich, Department from Cancer and Immunology, and Harvard Medical School. So they took note of this 2002 and 2000, and they started doing their research. And they published in this paper that this could be a global epidemic 5 years earlier. And this was funded by if you go to this paper, this was funded and supported by the National Institute of Allergy and Infectious Disease, NIH, under the special grant, and a special permission was taken, and CDC had given a statement to NIH, we have verified the lab, it maintains all the biomedical safety, and there is no danger of this virus coming. This is published in Nature, huge article. Now, for a while, coming back to what is my role? I'm not here to talk the history. So in the month of February, when COVID started coming in, Jodhpur was one of the places where tourists were there, and we had very early, and we had a wonderful microbiology lab. It was already equipped with all the testing devices for all viral, and it was already working with National Institute of Virology, Pune. So when I read this paper, this was the fear. Now, what I tell you is that a lot of things, what is coronaphobia to a doctor, to a common man, now this is a paper which got published, and it showed that pregnancy is a dangerous proposition during COVID times. You will have a cytokine storm, you will have a hypercoagulopathy, you'll have a maternal hypoxia, you'll have a placental infection. And I said, what? And there were guidelines from CDC, don't take it lightly. If the mother is COVID positive, remove the child. The child should not see the mother's face. There should be a complete barrier. The child should not take the mother's milk. Now, as a neonatologist and working on the neonatal brain, I knew that when you are born, all of us are born, brain is not mature. In fact, as a primate, we have the most immature brain we can think of. And once the mother sees the child, brings close to her breast, the smell of the mother, the touch of the mother, the look of the mother, all these sensory organs, which in Sanskrit we call the Dhyanendriya, helps the wiring of the brain, which is so, so important for the brain formation. And it would be terrible to separate the mother and the child. That's really nature would like it to do so. And so very early, I said to myself that I'm not going to separate them. So I took permission from the director. I said, sir, I'm going to increase my capacity of 6-bedded ICU. It will be 20-bedded. I don't want any leave. I promise you that my entire team, from the nursing staff, ward boy, didn't work on 30% as was recommended. We worked on 100%, no leaves, nothing, Sundays, holidays. We had only one motive: no child with any collateral problem or fear of coronaphobia should be denied treatment. And we developed a for COVID mothers, another ICU, where mother and the child would be kept because there was a huge fear among the obstetricians and other clinicians. And this is what we developed it for it. Remember, at that time, the ICMR guideline was to separate the mother and the child. Surprising. We thought of doing a research with help of IGIB. So we applied for a small grant.
Dr. Arun Singh, 1 minute, Chakpani here. Are you saying that ICMR guidelines even today prescribe that the mother and child be kept separate in the case of a corona positive mother? Immediately after
birth? Good question, sir. Now that guideline has been changed by Government of India. Government of India not only changed the guideline, but it invited me for a webinar for all the doctors and the administrators across the country to say that don't separate them. But I'm talking of early features.
Right.
And early, there was a lot of phobia because the Western press, the CDC guidelines, was creating this. So I don't mind ICMR talking about this because all of us, we know that we do follow the Western guidelines, and especially we honor the CDC a lot. And I think one of the lessons which I have learned is we in India are good enough, our brains are intelligent, we should follow our own guidelines, depend upon our own purpose. Perhaps in such times, this in a retrospect would be better. But very soon I found, and this is a guideline coming on 14th October 2020 from Royal College of Obstetricians and Gynecology and Royal College of Midwives. So the initial CDC guideline said the pregnant women are more in danger, and I repeat, are more at danger of having COVID and having severe symptoms than non-pregnant mothers. But today the guidelines from the Royal College of Obstetrics and Guidelines, and even the CDC is now changed, most pregnant women who are infected have experienced only mild or moderate cold flu-like symptoms. And they have now done 11,000 and more so, and they found that the majority, 75%, have no symptoms. Now I'm just telling you, we were very worried. We identified virus in the breast milk. We identified virus in the stool of the newborn. We identified virus from the mother. We were doing sequencing. They were the same virus. We were thinking of a very good publication. But there was a problem. We were taking 20 samples from DAG, that means one mother and one newborn, at various periods. We were taking 20 samples. The mothers were extremely unhappy. Why do you want to take our samples? I said, because you're COVID. I said, so what? I don't have fever. I have nothing. You are telling me I'm COVID positive, but I don't have any respiratory distress. My saturations are good. Why do you want to do all this? I'm not going to sample you. I thought that there's something which I'm missing. And I'll talk to it last, because as the doctor, I was a complete failure in understanding what the mothers was telling me and how should I relate. I kept on doing this study for a pretty long time, till date. And now this guideline says that most of the preterm births, which the CD said is going to happen because of COVID, 94% was iatrogenic. That means it was because we doctors decided it. That's not good for the mother or not good for the child. And 6%, this is from UK, the mothers insisted we are not going to have a normal delivery. Just cut our abdomen open and take our child. But now we know from the study also that there is no problem of congenital abnormality if you become COVID positive. And there is no problem of increasing stillbirth and neonatal death. You don't need to do cesarean. Even if you keep the child together, there's no added problem. Yeah, some newborns became positive. It was 1 to 2% in our case. The global study says 4%, but they had no symptoms. Question was, why is it that they are having no symptoms? I didn't have an answer. Today I have. I'll come to it the last. This is yes, sir. This is a BMJ article which now is talking about the clinical manifestations of the coronavirus and the systemic review meta-analysis published in September 2020. Pregnant and recently pregnant are less likely to manifest COVID-related symptoms. So what my mother was telling me now is a published data that they are having less symptoms of fever and myalgia as compared to a non-pregnant woman of the reproductive age group, and are potentially more likely because if there's a fear that if something happens, will it only requires if there's a pre-existing comorbidity of high maternal age, high body mass index, that means they're obese, or suffering from diabetes, do they require something? But our own data of more than 100 mothers and child, we found none of them required ICU cares. In fact, none of them required any hospital stay. It was just, we used to wear the PP suit, go and see the mother and the child. Majority of the time, they were just normal, excepting barring one in which there was preeclampsia. Yes, sir. Any questions, sir?
No question. Please go ahead. I think.
Okay.
Yeah, please go ahead.
Now, see how we get confused. This was an article published in Lancet, and I called, so one dogma was that pregnant mothers are more at risk than non-pregnant reproductive mothers. And today that dogma is broken. The second dogma was that if you are going to suffer from, if you are going getting admitted to ICU, if your lung is damaged, you have a higher viral load. So higher viral load means more infection. And this came from the Lancet publication, which was published in June. And this was a CT ratio, delta CT. So CT means the number of times you need to amplify that virus to show it becomes positive. So if the viral load is less, you need to amplify it more. So if you have got a higher CT, then you have a lower viral load. And if you have a lower CT, then you have a high viral load. That means you don't need to amplify even with one amplification or two amplification you could see. Normally we do 40 times amplify the RNA material to get enough to get it positive. Now this is showing that the mild and severe case the severe ones have higher viral load as compared to mild. Was it a dogma? Was it scientifically done? Just because it got published in one of the most reputed journals, do we need to believe in it? Now let's question this, the second dogma of my presentation. Now, this is a very interesting study which has come from Republic of Korea. And you can see this got published in JAMA. And it says that both symptomatic and asymptomatic patients, when the viral load was studied, to their utter surprise, the CT values in asymptomatic patients were slightly higher or very similar to symptomatic patients. This is very surprisingly. All along we believed we are going to wear more mask, more protection, that at least there is less viral load in my body. Now are you trying to tell me that the healthy asymptomatic population has the same viral load as the person who died of COVID? So is the virus not going to do anything? What is it? Now, I honor Telangana for this. Very independent and with a very brave statement came from a study. And this Indian scientists find higher viral load in asymptomatic patients, much against the Western press. And this was done in Telangana. Any guesses where was it done? It was done at CDC, Hyderabad. Let's value these centers which have been created in the government sector. Let's value the scientists which did not get swayed by the popular statement, and they came up. Though it was only 200 patients, but this supported, and let me tell you, the South Korea document came much later, and this came much earlier. And today the whole country knows that your city values and your virus load is not a reflection of the damage which is happening to your lung. So what is it that is damaging?
Dr. Singh, can you kindly amplify what you have just now stated? I mean, from a layman's perspective.
So I'm trying to tell that, let's say 100 people get infected with the same virus, no extra virulence. And if I study the viral load among those who have to get admitted, who go on oxygen, who have to go on ventilator, versus those who are very mild disease or asymptomatic, that means they have no symptoms, they're a healthy population, they don't even know that they have COVID unless until you test for them. Both of them, the Korean study showed they are equal, but the Indian scientists showed that if you are asymptomatic, you never got admitted to ICU, your chest x-rays were normal, your CT was normal, you had higher viral load as compared to those who were unfortunately had to get admitted in ICU, and some people who died. This is questioning a basic concept, that is the viral load equivalent to my damage in the lung? So is it clear, sir, now?
Yeah, which means you are basically saying virus in itself is not going to be damaging. Is that what you're saying? There are other attending factors.
Correct, sir. Correct, sir. And had we studied the 2002 paper, or I can share with all of you the 2005 paper, because in the 2005 paper, the Italian scientist in the last 5 lines says a very important remark. I'll share this paper with all of you. Please read the last 5 lines. He says, I'm writing this paper in 2005. If for next few years there is no COVID, people will forget it. Funds will dry down. Nobody will do any research. And I'm afraid people will forget. But I can predict that since this SARS-CoV-1 has come from the bat, the natural host is already there. One day it will come back again and we will not know what to do. By this time, the entire energy of trying to get a vaccine would have stopped because funds would have dried. His prophetic statement came so true that it tells me that while you should read what is happening correctly, you should also go back to history, genuine history that helps in a lot of experimentation. So perhaps this is the reason why the viruses, which in the case of Diamond Princess ship, where 700 people had it, all of them were marooned in the sea, only 0.35%, though their age was 70, died. But I'll come to this answer much later, because from February, I could not understand this. I can only understand the sky became clear when I suffered from this. And so I share what I suffered from. But this is my data. So just to tell you, I was living with COVID. I was seeing COVID patients. The room from which I'm doing this, next door, I have some thousands of COVID viruses in the lab, kept in the solution. We were doing sequencing. We were doing precautions, but I knew someday I would get COVID. And I was waiting, what features will come in me? Now, my student, who was a DM student, he came to me and said, sir, I'm feeling malaise. I said, we have our own lab. Why don't you get it tested? So he got tested. And by evening, he told me, sir, I'm positive, but I'm afraid you should also get it tested. I said, wait, this was exact date. I was 28th and 29th. He insisted, so I got myself tested. I had no features. My report came positive. I did his cytokines, which was correctly normal. What are cytokines? Cytokines is produced by your own cells, depending upon how healthy you are. So I didn't get my cytokines done on 29th, but on 30th I had fever. The problem one is that I was staying alone in the guest house of AIDS, and I found that the staff was very worried I'm COVID positive. So though they didn't say anything, but seeing their faces, I got worried, so I got admitted. Not for any reason, but the first I got admitted in the ward, the night of 30th. And because I was admitted, the protocol said my investigation should take place. So my total count was 6,990. My platelets was 3.13. These are all normals. My HSCRP, which is a highly sensitive CRP, which depends upon the response of your cell, was 12 as compared to my student who had 4. Very quickly, I told my student, let's do the sequencing of your and mine. And in the next 7 days, I would like to see if the 2 viruses sequences, they match or are they mutated. But by 30th, I started having fever. Now, when the cytokine report came, which is HSCRP, IL-6 was 85. The normal would be about 1 or 2. 4 is maximum. LDH was slightly raised, but the D-dimer was surprisingly, the machine couldn't measure it. And this was only the second day or the first day of my symptoms. The machine could only measure at 20. The normal value would be 0.3 to 0.5. So the resident got perturbed. They shifted me to the ICU. The same night, I got a CT done for my chest. The CT was perfectly normal. But because of the cytokines, a junior resident felt, so how to help you? So I still qualified as a mild disease because my saturations were normal. My CT was normal. But I told, why don't you give me steroid? Because I had read in 2002-3, very early steroid helps. So steroid was given on the night of 30th. And on 2nd, when I did my HSCRP, it was 4.6. My procalcitonin was normal because they were also thinking of secondary infection. But because I was given steroid, my blood sugars were haywire. My D-dimer came down from greater than 20 to 0.74. They started doubting the first value. On 4th, my count had become lower. My IL-6 were now normal, 1.3. My D-dimer was 0.13. And 4th, 9th, I was told by the Dr. Singh, you could be discharged, though you are still COVID positive, but we can't help you. We can't keep you in the ICU. We'll tell the staff, you are on the lower side of infection rate, so they'll keep the food outside your window. You can take it, but we discharge. I was slightly reluctant whether to stop the steroid so early, but they said you are a mild disease. You didn't require the steroid in the first place. And that is why we are not giving you anything. So I was discharged on 5th. 6th and 7th, I was very good. I don't have a car here, so I cycled from the guest house to my clinical work. I think I'm the only clinician who uses a cycle. So some of my students and some of the consultants saw me cycling, and they thought, oh, this fellow is just away from COVID and is cycling. This is not proper. So the word spread around that Dr. Singh is not doing the right thing. But by 8th morning, the effect of steroid, which was dexamethasone, was weaning out, and I started developing fever. Since I was staying alone, I was measuring my blood pressures. Surprisingly, it was falling down. And by evening, I was almost in a shock. I had to shift it to the ICU, now in an ambulance. The first time I walked to the unit and got admitted, this time I was almost wheeled. My blood pressure systolic could not be measured. They started giving me fluid. It was not coming up. They got this time HSCRP done, which is doing through contrast, which took a lot of time, exposed to a lot of ionizing radiation. CT was perfectly normal. Saturations were low, but CT was normal. I again requested their son, can you give me a steroid? He said, sir, I'll give you, but tomorrow there'll be a meeting of all the experts. You are a faculty here, and you are a head of department, and you are 60 years. So tonight I give you, but don't ask for it tomorrow. So I was given steroid, and by 10th, my cytokine report was showing that my IL-6, which had risen from 1.3 to 11.3, my HSCRP, which had come from 4.6 to 38.5, and my D-dimer, which was 0.3, which is normal, again had gone to greater than 20. My ferritin was slightly on the higher side, but on 9th they stopped. So the consultant said, Dr. Singh, we don't believe you have any problem. You had cycled and so you had a problem. Now we are going to keep you strict rest until you are COVID positive, will be here. The day you are negative, you are going to go home. But 9th, 10th, again I had fever. At this time, they were not ready to listen to this fever. They were not ready to listen to the cytokines. So I did my experimentation on myself. I started taking oral steroid dexamethasone 3 milligram, without knowing that's the best dose. My sugars were pretty high, so they had to give insulin. And I was fearing that if I take steroid, will my viral load increase because I'm getting immunosuppressed, and so I'll continue to be positive. But that was a very happy note. On 13th, I got negative. So I was discharged. On 14th, I go back, test my HSCRP, which was 38.5. It had come to 21.7. IL-6, which had come down on 10th, but again, because I had not taken steroid, it had gone up 71.5, and I was taking very little because I was afraid I don't want to get addicted to steroid. But my D-dimer was 0.3. My ferritin was greater than 2,000. That's pretty high. That does happen if you have. So with this, this was a newfound knowledge.
Dr. Singh, sorry for the interruption.
Yes, sir, please.
Is this not part of the protocol of treatment, this treatment with steroids?
No, sir. The protocol, which is based on a recovery trial, and I would request that those who have not read the recovery trial from UK must read it, because they found they used dexamethasone only for people who had been admitted. Like I was admitted not on 1st but on 8th. That means 8 days. And if you are found to have a cytokine storm and your lungs are involved, then they gave dexamethasone for 10 days. And they said that recovery trial says giving dexamethasone is a cheap drug, very useful drug. And this is before the solidity trial. They said that giving antivirals didn't help. Giving this drug, which is so cheap, actually saved so many lives. So many people did not go on to ventilator, and so many people did not require oxygen. And they conclude that the most important discovery of 2020, based on the recovery trial, was dexamethasone. But nobody gave dexamethasone because when you are talking of the storm, I would remind you of 19, I think it was 96 or 97, when there was a huge storm in Orissa. I remember because I was still in the AIMS, and the people, the boys who in the mess used to cook were mostly from Orissa. They were crying because there was devastation. So before the storm, there has to be a pre-storm. Your HSCRP started from 12. So if I include this pre-storm, I had already a high HSCRP. The pre-storm showed I had an interleukin 6 of 85. The pre-storm showed I had a D-dimer of greater than 20. Now, the current protocol is that you give antiviral and you give steroid when you are readmitted with very high cytokine, which you call the storm. My question is, can't we, if cytokines and not the virus is doing the damage, can't we prevent it in the pre-storm? So now Orissa's storm, now you don't treat and wait for the storm. You understand the pre-storm, you take all the precautions, and so perhaps it was not storm, it was post-storm, because all these cytokines would have already damaged the lung. And I can vouch that the DHS, he rang me up exactly on 13th, and he said, I heard that you are readmitted, the Director Health Service of West Bengal, Dr. Ajay Chakravarti, and then to help me to said, he said, I also suffered along with my wife. It's already 10 days. I got a lot of antivirals and steroid. I'm good. I said, in seniors in Bengali, we call them Dada. He was my senior in college. I said, Dada, forget about me. Have you done your cytokines? He said, why are you tolling? My ferritin is great, more than 2,000, but that will come down. All my cytokines are normal. My IL-6, my HSCRP. I said, sir, do it after 2 days. He said, are you sure I need to do it? I'm feeling very weak, that's all. I said, why are you feeling weak? Do it. And after 2 days, all his cytokines were very high. And then he said, what do I need to do? I said, Dada, go back to steroid. That's the only drug which we know can immunosuppress, can put down your cytokines. Do a clinical scoring, maintain your cytokines, put a score from 1 to 10. The next day he writes, my weakness has improved. Though my blood sugars have gone up very high, I have started on dexamethasone, 4 milligram BD. But yes, my cytokines 24 hours later have come normal. He asked me the next question, how long should I take? I said, that's $1 million question. But my best guess is 4 weeks, because at that time, I had not read an article which has just got published day before yesterday. So I would say, what did I learn from me? I learned it was not the virus. That is why your city values were not showing. The viral load is the same between and my student. The virulence is the same. Even the Chinese premier was saying the virulence would increase. So what did COVID do? Both in my student and my case, it just opened the lid. In my case, because of my stress, because I was 60 years, because of the stressful life of a doctor, which started when I became a doctor at the age of 21, all my cytokines must have been raised. So it was released. In my student case, who had no symptoms, they were not. While I was admitted, I checked the record of all those who had got admitted. There was not a single case whose cytokines was normal, but he was suffering from, he was requiring oxygen, or his chest X-ray showed any whiteout lesion. Everyone's cytokine was normal. Post-cytokine, a lot of people were dying because the moment you become COVID negative, I became COVID negative on 13/10, but still my cytokines are high. Even yesterday I did, my HSCRP is still 15. It's not normal. And I know that I need to titrate. The day I don't take steroid, I can't work. I couldn't have delivered this lecture. Last night, I prepared the slide the whole night. I'm not telling to change your opinion. This is an insight. Certainly, the sky looks very clear. So you may become COVID positive or negative. It's not the COVID virus which is damaging your lung. It's not damaging your heart. It's not damaging your liver. It is being done by the cytokines. Why to wait for the storm, where the recovery trial showed it is working better than the antivirals, the solidity trial is showing the hydroxychloroquine, all this is not working. Then I did this experiment for 5 more doctors. I can tell you by 5th or 6th day, if you are not taking steroid good enough to dip your cytokines, and this cannot be, the dose cannot be decided by me. The clinicians have to decide based on how much amount of cytokines is released and how long will it be released, depending upon your comorbidity, depending upon what kind of cells you are leaving. And so you need to monitor it by showing that cytokines are normal. If you do so, my best case is the lungs and livers won't be damaged. Even if it is damaged, they will not recover normally. You will be handicapped. There are some patients who are waiting for lung transplant in USA. The solidity trial, the recovery trial said very correctly, there's only one drug which is the magical drug. And let me tell you, when we Indians, our death rates are low. Yes, they are low. When it was the director of IGIB, I was talking to him yesterday. He said, yes, we understand this because people thought India has low death rate because you have a younger population. But when he matched it with age control, we found that still our death rate was low because in the villages, in the cracks, the Somtech, the simple practitioners, they are very, very liberal with steroid. They'll give you in the same injection a gentamicin and steroid. I'm not advocating that, but perhaps that was pushing the cytokines and we survived more than anybody else.
Now, Dr. Singh, just one point.
Yes, sir.
Can I read out what Mrs. Priti Sudan has said? I sent it to you also.
Yes.
Do you think, shall I read it out so that you can respond?
Yes, sir.
Mrs. Priti Sudan, former Secretary Health, when I sent her the link for your presentation today,
yes, sir,
she sent me this message. I'll just read it out for the benefit of all. Hope Dr. Arun Singh tells his experience of readmission to the hospital and not to take COVID casually. Rest and go slow is most important. That's what she said. Apart from healthy diet, breathing exercises, steaming and vitamins are, that's what she said, are essential. Now, how would you like to react? This is what the former secretary.
Yes, so I must thank her because when I got readmitted, I got a message from her. And in the message she said, Dr. Singh, please recover. I can tell to all of you, she may be a bureaucrat, but she has a grasp on science. And she told in one line, don't cycle. So I understood cycling. Now I tell you, to all of you, once I was discharged to test myself, I joined back my duties, hardcore duties. That means ICUs, not taking rest. And my own experience says that somehow this COVID is suppressing the normal steroid suppression. I have to take steroid to bring down my cytokines. My weakness goes away. But yes, during the admission, one thing I would like to tell all of the people, you can go to the WHO document. I must say that the COVID ICUs were locked, the windows were locked and there was an AC. I would request that all government sectors, if you have an AC, it can amplify the viral load. If you don't have a HVAC, that means a UV light to kill the virus. If you don't have, check your duct. If you don't have not only a HEPA filter, but a MRF filter, and if you are recirculating the same air. I do not know why are we doing this. If you are in open air, put on the fan, and this is a document from WHO regarding COVID. It says, please open the windows and doors, allow the cross ventilation to take place. If you have a ceiling fan, open it, let the air change. Because if you remember, in China, in a double-decker bus, the person who was COVID positive was on the top floor. The people in the lower floor suffered because there was AC. In that famous Italian church, where one lady infected all she could only do because the whole church was locked and the AC was running very strongly. That means the cycles were there. So each time the same air is getting circulated, it is getting sucked in and recirculated and recirculated. So the COVID virus will do. So one of the message I would like to make to everyone, if you are in government sector, if you are in malls, if you are in hospitals with centralized AC, please be very careful. If you're not checked your duct, if you don't have MOF filters, you don't have HEPA filters, if you don't have HVAC system, please stop your central AC, open your windows, open your doors. Your cross ventilation is much helpful. So I think, yes, she is right. You should go and do respiratory, get fresh air. Because remember, Legionella disease was caused by ACs. The huge number of viral and fungal infection which are caused by AC ducts because they recirculate. AIMS New Delhi had to close it cardiothoracic because a famous minister from South, he died because of the wall replacement. He developed a fungal infection. And the then chief, who later on went to become the director, immediately got the whole duct changed. So this is well known that AC ducts are sources of infection. My only request is, yes, I agree with Madam that you need to. But what my question is, a lot of people who have become COVID negative like me can still die because the cytokine load is still high. The COVID virus, it just opens. How long the cytokines will depend cannot be individualized, has to be individualized, cannot be generalized. So I would say your weakness is also a symptom, and that is related to some cause. In medical science, in science, any symptom, including weakness, when people talk, there has to be a reason. And at least my own understanding is that that reason is that your steroids are suppressed, the cytokines are high, and you can go damage. I will please wait for my few next slides, which I will show, which will further clarify what I'm thinking. A very, very important document. I talked to someone in Calcutta because, I was a professor there for a pretty long time, and I left Calcutta in 2012. What is happening to those who are immunosuppressed? And you know that kidney transplant patients, they get immunosuppressant. So ideally, if they are going to get COVID, their body immune system is not going to react, and they will have huge virus load, and they would die. So she told me, and this paper she has already written, and it has been accepted. I'm waiting for its publication. I wanted it to share with you, but she said since she has already submitted the paper, she'll not be able to face it. But she told me the important finding. Dr. Arpita Rai Chaudhary, who is the professor and head of IPGMR Kolkata, she said, during these 7-8 months, the patients where I did not remove the immunosuppressant drug, which in the Western world, a lot of doctors did with fear of COVID. When they had COVID, they did much better than the rest. Death rate was lower. Then I thought, has it been reported by someone else? And this is a paper. They distributed it in 4 types. The type 4, and these are all patients who had kidney transplant and they were on immunosuppressant. They found that the lymphocyte count, the type 4 were the most critical patients. There were 15 in number. There were 41 total. There were maximum death in their critical patients. Type 1 was with mild symptoms. And they had 3 approach. Approach A, approach B, and approach C. This was a randomized controlled trial. In approach A, they gave all the 3 immunosuppressants, including the antimetabolite. In approach B, they removed the antimetabolite because the antimetabolite can bring down the lymphocyte count. And this type 1, type 2, type 3, type 4 was based on severity, based on the lymphocyte count and creatinine count. The approach C was you need to add steroid and also use some other drugs for further immunosuppression. So these were the 3 approaches. What did the study show? The study showed that the type 1, which were the mild symptoms, if you allowed the immunosuppressive Nobody died. The type 2, where they had some symptoms, they only suspended the antimetabolites but continued with the anti-immunosuppressive. And in the last variety, type 3 and type 4, they did not remove the immunosuppressant. In type 4, patients went on to ventilator, but they used CNI, which is basically a drug which further suppresses the cytokines and corticosteroids. They said, please give it because you don't want the cytokine storm. That would damage the patients with renal transplant. So this again fits in with what I heard. Incidentally, the first doctor, Dr.Arun Singh, and these are personal experiences when I talked to him, because he was the first doctor in Calcutta as early as third week of March who got infected with COVID, little knowing that there's something called COVID. At that time, there was only one center testing, that was the ICMR center. So with 2 days fever, he presented to the ICU with low blood pressure. Dr. Dipankar Mukherjee was a professor and head of cardiology, didn't think of COVID, he thought of myocardial infarction because his blood pressure systolic was less than 100. So he thought of MI, he admitted him into the ICU along with other people without knowing the COVID status, and his was not rising. So he started using hydrocortisone, which is steroid, in very high doses to improve it. 2 days later, when he was found to be COVID positive, he was removed from there, put in isolation. But because he was started on steroid, his steroid continued. Remember, those were the days there was no antivirals, there was no other drugs. And today, he improved with only steroids. What did the steroid do? What this immunosuppression did? So is it that the Western world thought it differently? In fact, COVID is not bad if you are immunosuppressed. COVID is bad if you have a hyperimmune response, because that relieves more cytokines. Are there more studies for it? So this is James Todaro. He puts it on his Twitter handle. The Italian Society for Rheumatology studied 65,000 patients who were on hydroxychloroquine, which is an immunomodulator, and steroid for RA and lupus. Only 20 patients tested positive for COVID-19, no ICU, no deaths. He says 90% reduction. And we know that there is a cytokine storm, but there can be also pre-storm, and there's a cyclotherapy. Now, this is a very, very important study which was again published in Nature in October. While I was sick, I just found the study where it shows that the inflammatory cytokine is a signal of COVID-19 severity and survival. That means if your cytokines are very high, then you are a potential case to land up in ICU, to land up in hyperimmune response, because this paper says the hyperinflammatory response induced by severe acute respiratory syndrome is caused by cytokines and is a major cause of disease severity and death. And they looked at interleukin 6, interleukin 8, tumor necrosis factor, and IL-1 beta. But remember, this they only did hospitalized patients. They could be hospitalized even for suspicion of COVID. Some of them didn't turn out to be positive initially. Later on, they were cells. And he found that there was high serum IL-6, high IL-8, TNF-alpha, and it could predict the management and the death. So this study was done at Mount Sinai Health System in New York on 1,484, where they followed it up 41 days. This doesn't match with me because I got it done even before the cytokine storm. Even before I should be admitted, I got myself tested. And my second admission was actually the one requiring ICU, not the first one. So this is the paper, an inflammatory cytokine. And this is saying several studies have revealed that hyperinflammatory response induced by severe ARDS coronavirus 2 is a major cause of disease severity and death. And it says we propose that IL-6 and TNF-alpha should be considered in the management and treatment of patients with COVID-19 to stratify prospective clinical trials, guide resource allocation, and inform therapeutic location. So what did we find? We find that the infection starts 2.5 days before the symptom. So when you are quarantined, actually your infection rate is already. In fact, it peaks 0.6 day, which would be simply about 14 hours before your first symptom, you have spread maximum infection. And your maximum infection rate goes away by 7 days. Even you may RT-PCR make the proportion of transmission area under the curve before the onset of the symptom was already 44%. So you could still be shedding virus, but 44% you spread it before you knew this. So I am now going to tell you a wonderful paper which actually bears me out. Now this paper has been accepted by Lancet, and this is an advanced paper, and it is going to get permitted published next week. And I have also to take the permission to share with all of you. So what did this show? It shows that all this feeling of 10 days, 12 days, 15 days, 18 days is not correct. They actually studied the temporal clinical profile, and they found that the violet line is the temperature. So in the first 3 days, your temperature goes up and then it goes down. And then it rises again by 7 to 9 days. Again, it comes down to day 12. Again, it rises by day 15. Again, it comes. But yes, the number of patients are becoming low. But there will be a group of almost 5 patients who would still have high temperature. What about ARDS requiring intubation? They peak at day 10 and 12, which we call the cytokine storm, but again there's the second peak at day 19 and day 21. What about the onset of diarrhea? The onset of diarrhea is happening at day 4 to 6, and then it is peaking, and then it is coming down. So what it tells? It tells that you are going to have recurrent fever on day 8.9, which is a median of plus minus 3.1. You are going to have a watery diarrhea on the 7th or 8th or 9th day. There will be radiological deterioration in 80% of the cases on 7th or 8th day. There will be respiratory deterioration again, and about 45% of the patients, they will show initial improvement on CT scan, but about 20% in the 3rd week, which we don't see, again there is going to be a damage, new lesions are going to happen. And they found that age and chronic hepatitis B virus, incidentally, this was also true for COVID SARS-1, are independent significant risk factor for progression to ARDS on multivariate analysis. So when they started analyzing this paper, the interpretation which they gave, and they first broke the myth that you don't spread only through lungs. So this NPA is a nasopharyngeal aspirate. When on day 10, 95% tested positive. On day 30, still 90%. And on day 21, still 47.4%. But stool was also positive. And this is also true when they studied the Connecticut study, which was at Yale, that they could find that the sewerage COVID virus load increased with the hospital admission in Connecticut, and it decreased when the patient came low. So the stool positivity rate is almost by day 16. Day 13, it is 100% positive. The urine positive is 50% by day 10 and 13. So what was the interpretation? Now this is the latest, which bears me out, and it's still not published. You'll have to wait for the next week to find the whole. But the interpretation is very important. The consistent clinical progression, the shifting radiological infiltrate, which comes back on the 3rd week, though in a very small group. An inverted V viral load profile suggests that deterioration during the 2nd week is not related to uncontrolled viral replication, but may rather be related to immunopathological damage. Age and hepatitis B virus status are risk factors for progression to ARDS. I think at least I'm happy that my findings have borne. This paper was just published 2 days back. And now I share with you of 7 cases which were given very high oxygen, where the blood gases are very poor, their CT scans were damaged. These were the patients which were admitted in the ICU. So lying on my bed, I went and saw the record. And to my utter surprise, a PO2 of 50, just to tell you, most of us will have a PO2 of 90 plus. The PO2 of 50 still had a pH of 7.42. The lactate were normal, so the saturations were low. This was very interesting. The PCO2 was not raised, excepting in one case. That means even with a oxygen saturation of 35, a PO2 of 20, patients were surviving. But where does the oxygen is required? Oxygen is not required by the lung. Oxygen is not required in your blood. Where we measure, the final destination of oxygen is at the cell. And at the cell, we have a powerhouse that generates ATP, the currency of energy. This ATP requires oxygen and sugar. Mitochondria requires very little oxygen. I can show you Sherpas which can climb the Everest without any oxygen cylinder. Their PO2s are 30. So if you can acclimatize, your cells can store very nice with very low. In children with congenital heart disease, we find low oxygen saturation, but their lactates. Now, why lactates are high? If your cell is not getting enough oxygen, it cannot follow the aerobic circulation to produce more ATPs. It switches to anaerobic, and then it produces less ATPs. So somehow the cell is happy, and that is why you are happy. One doctor from USA said, I have never intubated a person whom I had to tell, remove your phone, I need to intubate you. Usually when you intubate, the patient is having air hunger. Either he's comatose or he is gasping for air, and you intubate. Here I'm intubating a person who is talking to someone on the phone just because there's CO2. I'm raising this question that is it the cytokine even before impacting the lung? Is it impacting the hemoglobin, the porphyrin ring, and maybe even that low oxygen is good enough for the cell? I'm not commenting on this. I'm just sharing you the actual data, which is very, very surprising. I would have expected that body would have told, listen, you have to take more respiration. There has to be metabolic acidosis. The lactates will go up. That's what we have seen all the life. So then all this lockdown, all this fear, does it mean? Now this is a beautiful paper which has done about 100 countries. And this shows that the mortality was associated with higher obesity, because higher obesity, remember, leads to more cytokines. But lockdown and etc. didn't decrease the death rates. But what very interestingly showed that the number of nurses which you have per million population has a huge impact on the people. I can vouch that majority of the time I was taken care by the nurse. So if you have more than 6,000 nurses per million population, the death rate per million population due to COVID was something between 23 and 25. But if you had less than 3,000 per million, your death rate was almost 140, 140. All of you can read this paper. Now, what I'm trying to say is that I stop here. I've taken your time. What are the messages I'm trying to say? I'm not asking to change your protocol. I'm not asking not to take a rest. I'm asking 3 questions. Can we, before the storm, monitor the cytokines? And since we know that dexamethasone, both in the trial, which is solidarity trial done in 30 countries, and also in the trial done in UK, the recovery trial, both the trials showed antivirals have a major role in dexamethasone, and we doctors know how to treat such diseases where immune system is hyper. there will be more than 100 diseases. We know how to treat with steroid and how to bring it down. Can we leave it to the doctors? But my basic point is, can we start looking at day 2 or day 3 of the cytokines? And you may not give anything, but if the cytokines are high, try to see whether they are the ones who land with lung damage. My second point is that after you become COVID negative, some of the people are dying. Can we monitor the cytokines to prevent the death? This is just a thought process. I'm not trying to convince you one way or the other, but certain myths which were there, that the viral load was impacting the severity, that the pregnant woman, now let me tell you, I got the answer. Pregnant women by nature are immunosuppressed. Nature doesn't want it to react. The newborns are immunosuppressed. So they were having COVID virus, but the cytokine levels were not. I checked it. It's too early. I will publish this work once I've done the data. I was looking at the virus. I was not looking at the cytokine. I was not looking at the mothers. The kidney transplant patients, if you had suppressed the cytokines, there's less damage. I rest my case with these arguments to all of you. Think about it. If it appears, it makes some meaning. If it saves any one life, I think my effort last night, which I lost my slides and did again, would be useful. Thank you very much, sir, for giving me this wonderful opportunity to speak one. I say yes, this does not mean change your opinion, but just have a thought. Thank you, sir.
Thank you, Dr. Arun Singh, for a very wonderful and I must say a heroic effort coming as it does from you after you've been ill and down with COVID. And I'm really extremely grateful to you for your presentation. And any questions from anybody? Mr. Venkateshwarlu? Venkateshwar garu, would you like to say anything? He is asking a question, dear doctor, how immunosuppressants be? I mean, Venkateshwar, would you like to articulate your views?
Not able to get my dear doctor, my question is, when our immunity is strong, we don't get diseases.
Yes,
but
sir.
Here is a fact: when immunosuppressants are helping people
Yes,
from getting into COVID-19.
Yes, sir.
Will you please answer?
Yes, sir. This is a question all of us were foxed. So there were a lot of pointers to it. A study from Hyderabad was showing that those who actually had higher viral load were asymptomatic because they were not reacting to it. See, you have to understand tuberculosis. In tuberculosis, it is not the tubercular bacteria per se which does the damage in adult tuberculosis. It is a high sensitivity reaction, that is the body immune response, which throws against the tubercular bacteria, which causes the damage. So there are a lot of cases like rheumatoid arthritis, like SLE, like fulminating hepatic failure, where the extra response, it is like if someone is coming to your room and he's abusing you, you just keep quiet and you're not using your brain, you're not responding. Or you may respond with a fight and you say, I need to counter, and your body response is actually showing a huge response. So, sir, actually, this only shows that the virus, which was from the Diamond Princess ship, showing that it's not a great virus. It's not that as if anyone coming in contact is going to die. It is just that the difference between you and me and another 5 people is how my immune response is going to react to this virus. And if I'm going to react in a huge way, Even if the virus load is more, even if I have become negative, my cytokines are not going to stop. They are going to. So you found even in the third week, by second week, majority of the patients had become negative. Their RT-PCRs were negative. Why in the third week did the people have high damage of CT when their CT lungs were normal? This could only be explained that the virus just was a trigger. It is just like a mirror. It tells you, listen, dear, I have opened you. Now your body, your cytokines, you need to understand how they are going to come. And so this has to be individualized. And when you are using immunosuppressant, you are not allowing your immune system to respond to the virus. So let the virus be there. Your body will clear the virus by its own. There are so many viral infections which every day. So the first, if you go the origin of life, then virus started, we started the journey with virus, which is between living and non-living. The human genome virus has, our genome, if you study the genome, has 12% which is carrying something which we got from the virus. This is known as retrotransposons, which our genome carries, showing that we have originated from the virus. So in this evolution process, the viruses cannot exist outside the cell. They become living only when they enter a cell. But they cannot do the damage. At least COVID-2 cannot, COVID-1 cannot. They can enter a cell. It will stimulate your cytokines of the cell. And depending upon what kind of cytokines, someone will remain asymptomatic and someone will go on to have florid symptoms and some may die.
Any other?
Did I answer your question, sir?
Yeah, it seems, say, you are the doctor, you know what is happening in the field, you experienced it, and your experience carries a lot of weight. We are outsiders. We have to learn something from you only.
No, sir. In this country, science doesn't belong to doctors. I think it belongs to all of you. You people are philosophers, you are learned people. I think that mother which was telling that I'm having COVID, but I'm having no symptoms, she was the most important because the cytokines was normal. I was naive, I was not looking at it. I was looking at the virus till I had myself. My second thing is my message to all those who are getting discharged from the ICUs on day 20 or day 17. You people feel very happy. Just monitor your cytokines. Don't do any treatment. And if your cytokines are high, please go back to the doctor. Please just go back to the doctors. That's all. And weakness is also an important symptom in post-COVID. And if you are already viral negative, why are you weak? And this could apply to lot many viruses. You see in case of dengue, the first time you get dengue, you don't suffer so much. The dengue hemorrhagic fever, which kills, happens when you get the second time. And I was thinking the second time, your immune response is more sensitive, your memory cells are more sensitive, and maybe you're through. So this is a new era which is going to open. But my basic message is anyone who has fever, whether you get your COVID test or not done, get your cytokines done. If they are high, go to your doctor. If you have been discharged from COVID, if your cytokines are high, go back to the doctor. So this is all my plea. Perhaps this simple message can save something. And don't put on your AC. Keep your breathing exercise in fresh air. Maintain a distance. While you are breathing, you don't require mask. Allow fresh air to go. But maintain a safe distance early in the morning when there's a lot of oxygen. Allow air to come in. Yes.
Sir, the cytokine test, sorry.
Yes, sir.
Cytokine test is done by most of the laboratories. How costly is that, or how? What's the price now?
This is $1 million question. I was talking to the IGIB director, and he said, Dr. Singh, I gave this drug on day one to all my relatives. So there are a lot of people who are actually giving it. Now, to do cytokines is pretty costly unless and until all of us unite and try to say, can we even in a village do the cytokines? But if you cannot do it, at least do one cytokine, which can be done in 50 rupees, HSCRP. This you can do without a doctor, without a proper pathologist. Any technician with a good machine can treat it. And I believe, sir, if we can make temples, if we can make statues, we in this country, if we decide, and not doctors alone, every person decides that COVID may go away. Tomorrow, some other virus will come, and they will also stimulate the cytokines. Remember, sir, even eclampsia, we should monitor the cytokines. So I would say a time has come. If India decides every small taluka can have a cytokine lab run by simple people, they don't require rocket science. But this on a mass scale has to be done. And if not, any simple lab will give you HSCRP. Anyone can be trained in 5 days. I in Calcutta used to run a lab which used to do the HSCRP right in my ICU without a pathologist. So I can vouch for that. So if there is a lack of money, that one good thing, let me tell you, when I compared my clinical features and I compared the paper which said that cytokines must be monitored, it is a good marker of severity of disease and death. That paper has also shown if your fever is more than 100.4 degree, if your lymphocyte counts are low, most likely your cytokines are high. You may test COVID, but remember, there is a limitation of RT-PCR. It is not 100%, it will not pick up. You may miss, but if your cytokines are high, you can almost close your eyes and say, you have something which has opened the lid and you require this cytokines. Go to the doctor, that's all I would say. Yes, sir.
Krishnagar, would you like to ask any questions?
Yeah, good evening, sir. It was a wonderful lecture, and thank you very much for giving so much of scientific inputs. But just before I asked, I think you have clarified that the PCR test is not really picking up the presence or absence of the COVID-19. Rather, it is advantageous to go for the cytokine test. Fortunately, your statement says that not many labs are available in the country, and if at all, if somebody has a mild fever, first thing to do is to look for a cytokine presence rather than rush for PCR. Is it the correct approach?
I would say, sir, doing cytokines is much easier than doing RT-PCR. If anybody decide, let's say you decide in South, you can do it in almost every small town, every small village.
Sir, do you need a lot of equipment for that, or the
No, sir. One equipment is going to do it. These are all ELISA-based tests. Some small training and etc. You could do it, sir.
I see.
What I'm trying to tell you, sir, that we in India can do remarkable work. Remember, sir, when the first ICU in India came, the Planning Commission asked me, how can you make this ICU, the Purulia model, in every district? This is too costly a model. Today, India has shown that every district has something in the government sector to show, and that is the Purulia model, which is far more complicated than doing cytokines.
A related observation on this from my side, I am Krishnaya, is that the claims of various state governments that they have done so many tests to detect the presence or absence of coronavirus among the people is not reflecting the real situation in the field, in the absence of not conducting cytokine tests.
So, what is our aim? Do we want to know how many people got infected? Or do we aim to prevent the death? If you are aiming to prevent the death, then doing cytokines is going to change the picture. If you are wanting to say, I'm going to invent something where this virus can be locked in with a lock and key, or we are going to lock the whole human population, well, you can try, sir. I can't be on that. So I think the fear which people had was not because people are having viral infection. Every day, all of you know that if you are getting common flu, which is a viral infection. The entire family members get it. You're not afraid of it because you know they're not going to die with it. So actually people were afraid of the death, and death was very low, and death could be prevented. I'm only saying my entire approach is shift from the number of people being COVID positive or negative. Shift to the cytokines. Cytokines will be raised out of 100. My guess is only in 2 people out of 100. But these are the 2 people who are going to die, who are going to go to the ICU. And a simple drug like dexamethasone could do the trick. Why do we? Why do we require these costly antiviral drugs, which is bleeding our resources, which is just helping the pharma company? We have got 2 trial reports. What are we waiting for? India was a part of the second trial, which was the
Oxford trial.
Solidity trial. And the London trial, which they could understand, the recovery trial, that only one drug worked, and they had put, there was a randomized control trial where they used antivirals, where they used hydroxychloroquine, which they had to stop because they were not convinced, and they used steroid alone. Steroid alone was much better than everything. That was what is the recovery trial. And they went on to say that the simple drug, the cost of which is so low, could save so many lives, so many people. It could actually bring down your load on your ICUs. It could bring down your oxygen requirement. It could bring down people dying. What more do you require? But the only logic which I'm now learning, work with pre-storm, which was not a part of the recovery trial, and even the storm has gone away. You have become COVID negative. Don't be complacent when do your cytokines. Weakness is also a sign of high cytokines.
And a last question from my side. Why is it that the protocols or the governments are not administering the cortisons and steroids when people know particularly that it is the basic preventer or saver of the death?
I think, Krishna, your question was not audible because of network problem. Can you kindly repeat?
My question is, when steroids could save their lives, why is it that doctors are not prescribing steroids?
A very good question. I asked this question, sir, I articulated your question to a lot of people, including the IGI director. He said, Dr. Singh, government always plays safe. We all know that steroid has side effect. Even if a single case dies because there is blood sugar has gone up, will not die, let's say, nobody monitored it. Or people start using steroid on their own. Then how could the government of India answer it? So he says, we have left to you doctors to talk, but giving into the guideline that you start taking early steroid and doing cytokines, we don't have the means to do cytokines. So what you say is good, but as of date, the private labs are actually bleeding you for cytokines, which is very cheap. It's only the scale of production. So in absence of cytokines, if we tell people, the message goes, people start eating steroids, and if there's a side effect, who bothers? So I'm not at all saying without doctor's permission, you start taking steroid. What I'm trying to tell you from the first case of the doctor who recovered with only steroid, from the recovery trial, from my own experience, is that if you ask your doctors, majority of the doctors would be doing the same. A lot of people are quite intelligent. It's only the thing is that as administrators, we have to find a process. So it is not we are trying to say what the quacks are doing is good, because anyway they are giving steroid. But you need to go steroid, but steroid is a drug. Let it be controlled. What I'm trying to tell you, that any doctor who can be trained how to use steroid, and they can't be a single dose. You have to monitor it according to your response. As you can see in that chart, some people after day 14 are not going to have cytokines. They're not going to have. But only 5 people did have, even on the 3rd week, a rise of the lung infiltrates, which was explained by cytokines. So you require a very small number to be given steroid early and monitor it once you are cured. But this would change the scenario. So I think if all administrators, if everyone says this message, yes, steroid is a great thing. I'm not saying, so read the recovery trial. The expert group just said, if in $1 you could treat and prevent so many deaths, let this be the drug of this choice. You see, what happens, we clinicians, either we become activists or we don't agree. The truth is somewhere in between. The truth is, all of us, if you're infected with this virus, the cytokine release is individualized. In case of males, it is more. If you have prostate cancer, it is more. If you have diabetes, it is more. But it is all individualized. How long it will be released, how much it is. So that report which is now showing is that you should monitor almost till 1 month. Because so many deaths have occurred when they became negative. And they had a brain hemorrhage, they had a heart failure. And so there's a phobia against COVID. People have become less human beings. With the neighbor, then, if it's COVID, then nobody's attending to them. The same thing happened to me. Nobody would touch you, even if you're a doctor. So there's a huge fear psychological. But when I checked with a lot of my consultants at AIMS Jodhpur, there are a lot of consultants who very quietly took steroid on day 1. There are a lot who took and stopped it and again had high cytokines and again took it. But yes, by reason of talking to all of you, is that I don't want to only talk to the medical world. Few people would know how to take it forward. I do not know, sir. I just shared, because to me now the sky is clear. I'm not at all confused. Whether I can convince you all or not is my limitation. But I know that even if I had not spoken, the truth would have been understood. The only thing, somebody in India understood the truth on his own. You can wait for the truth. You can wait for another 2-3 months, the truth will come out. I'm very sure. But this 2-3 months, we'll lose some more people. The reason why I requested, sir, to allow me to speak to all of you, though I know most of the people will not be interested. I'm not talking of a fanciful drug. I'm not talking of a vaccine. I'm talking of very simple. But let me tell you, all this could have been understood, sir, in 2002 and 2005. There's so much of resemblance of clinical features of SARS-CoV-2. And send you the paper, read it, and you will think, what were we doing for 15 years? I don't want to wait a single day. The day it was very clear, I just went to the literature and found out what are other papers which are supporting this. And today, this is like a necklace. It is not the viral load. It is not the virus. It is the cytokines. And once the cytokines start coming out, even if you become COVID negative, it continues to rise. Once there's a storm, don't wait for the storm. The people whose cytokines start going up, upward trend, that is where you start looking at it. Don't wait till you land with very high cytokines and with a lung damage, because any damage will heal by fibrosis, which is not normal.
Last 1 or 2 small issues and questions, sir.
Yes, sir.
One, the virus again is flaring up in European countries, US, etc. And one of the reasons they mention is that people are traveling extensively, or the schools are being reopened. What do you think should be the advice to bureaucrats here?
So, as I told you, there are 2 different questions and both are not linked. Initially, we thought that if less people are infected, there will be less deaths. But please remember, out of 100, only 2 people are having high cytokines. 98 are not going to happen. In case of the ship, you couldn't. So what am I trying to say? The paper which looked in 100 countries showed that our attempt to lock down the virus, our attempt to say that, okay, don't travel, is good enough it will slow down, but it also slows down your immune response, which in most of the cases, you are asymptomatic, a large majority. The only population which is affected is elderly population with these comorbidities. So what actually happened, the number of deaths is now more because the collateral damage, what did we create? I have diabetes. I'm not going to the hospital because AIMS Jodhpur also admits COVID patient and I will get COVID. So let my diabetes wait, let my tuberculosis wait, let my hypertension wait. And when I got COVID, then these were not under control. I became an extremely bad patient. So in some way as an administrator, we are also responsible that while we want to spread a message, coronaphobia actually didn't allow people with cancer, people with diabetes, people with hypertension. I have found newborns with osteomyelitis and they were not ready to come. They could be only treated because I didn't work with 30%. I tried to create out the fear. I knew the newborns were not having at risk of COVID. So there's a lot of population which was not at risk. So if you are trying to answer that, okay, the number of people infected I want to keep low, I don't think we have the right answers. Maybe in South, let's say in city of Hyderabad, if you test everyone, a lot of people are asymptomatic, but they already are COVID positive. Their RT-PCR may not pick them. That's what happened when everyone was tested in the ship. Only 20% of people tested positive. A lot of people must have been positive and become negative because they waited for 1 month. So you do not get the denominator, which is the number of people infected. So your death rate appears high. As an administrator, if you had tested everyone universal, you would have found that there was no reason to fear. The death rate was very low. But having the death rate low, if it impacts Dr. Singh, I will die. For my family, I'm important. And hence the reason is that please dissociate these two. For me, if you can measure my cytokines, you can predict that I'm the one who's going to die, and you can treat me with drugs. You can prevent my going to the ICU. In America, they didn't use so much steroid. So the recovery trial came from UK. We Indians have no special genes for COVID virus. Our health are poor. Are there some good reasons to keep the cytokines low? Yes. Pollution increases COVID virus, cytokines. So the virus only, just it opens the lid. You are already having high cytokines. Stress increases high cytokines. Eclampsia of pregnancy increases cytokines. There are n number of studies. We always knew of cytokines, we never appreciated it, that instead of talking to the virus, the damage is being done by the cytokines. And that is why the same virus with the same virulence, if it affects 10 people in the family, 1 person doesn't live, 9 live. Same treatment, same thing. The 1 person who didn't live, if you had done the cytokines, either we delayed giving the treatment because we waited for the storm to come, or after you became COVID negative, we tried to give the message, now you are COVID negative, now you have less virus, now you are okay, the weakness will go away, and he dies after 3 months. The whole shift has to be cytokines, and cytokines have clinical features. Even if you don't do the test, there are persons who have recurrent fever, persons who have high fever, persons who have symptomatic, are all people who are rising cytokines. But should we wait for the saturations to go down? Should we wait for the CT to show your lung are involved, which are all costly propositions? Can we do the cytokines early? I'm just saying as an administrator, sir, if you are convinced, then we'll find 1,000 ways to do it. If we are not convinced, we won't do it. But this investment will go even when the COVID will disappear. Other viruses will come. I think this is true for chikungunya. Why does chikungunya people have joint pain even after the chikungunya has left? Why does dengue, the first time you have, you survive, the second time you have to go into a severe symptoms? So I'm trying to tell you that cytokines is not just only for COVID. Our being healthy is not our weight, not our height, not our blood pressure low, our cytokines. Maybe if all of you do your cytokines, and if it is already raised, that means we are not healthy. Yes, sir.
Thank you very much, Dr. Arun Singh. Wonderful having you with us. We'll soon upload this. And probably I will also request you to share your presentation at a later date through the APHRDI to a larger group of doctors. I'm sure you would be willing.
Yeah, yes, sir. I'm willing to talk to everyone, doctors, even nursing staff, even veterinary people. I just wanted your guidance. How do you want? Sir, has this talk been recorded, sir, by someone?
Yeah, it is. It is. It will be sent back to you.
Okay, sir. So if you feel so, you can share this talk with a lot of people. I'm ready to stick out my neck. I'm ready to be criticized. If my getting criticized saves one life, I'm ready to face that.
Thank you, sir. Thank you. Wonderful having you. And please take care of your cytokines.
Yes, sir.
Monitor them regularly. I'm sure you should be doing it.
Thank you, doctor.
Get back to full normality, sir, and then we certainly need your help and all that.
I am fully normal. If you invite me, I can come to your place.
I will.
Don't fear me, sir. I have lived my life. Whatever useful I can do, that would be.
If you can request all the participants to unmute their phones and then give a big clap to the speaker.
Yeah. Thank you. Thank you very much, Dr. Arun Singh. Wonderful.
Sir, can I request you one thing?
Yeah.
Because madam is in WHO now.
Right.
And a lot of people, even my classmates, asked, even shared this presentation with her.
Yeah.
Maybe she may not agree, but at least I know Manoj Jhalani ji wanted. He said, whether anyone agrees or not, I will at least use it for my own relatives. So, sir, extensively let us share this if it is of any benefit. I'm not trying to change anyone's opinion. I'm not trying to change any treatment. All I'm trying to say, if you have enough money, please see your cytokines. Even if you are COVID negative, see your cytokines. That's all, sir.
Yeah, we will. What we will do is, number one, we'll share this presentation. Number two, we will have your talk live with a larger group of doctors, maybe in different parts of the country through the APHRDA. Okay?
Thank you very much, sir. And I will share all my presentation to you.
Yes.
Let me tell you, my slides are not my copyright. I always believe this. I give to my students. I have always given it, sir. You know me for a pretty long time.
Yeah.
Any one of you wanting it to use it, because at the end of the day, whatever I have learned is from patients. Whatever I am trying to tell you is from. I've just collated it. If any one of you want to use a part or a fraction or the whole, you are free to use it. There is no acknowledgement needed.
Sir, I would also
copyrights. Please go ahead and do it, sir.
I'll do it, but I would also like you to kindly prepare a 3-page general report which can go to the Secretaries of Health. Will that be possible?
Yes, sir, but I will require your help.
Certainly.
How would secretaries, since I know your understanding, sir, if all of you can help me with few points, how you conceive, what is it, the message which the secretaries would appeal to you, is telling these 3 messages that it is not the virus, because sir, this work has come from Hyderabad.
Correct.
I'm not doing it. Your Hyderabad, sir, the biggest center of the Government of India investment, the Center for DNA Fingerprinting, where such stalwarts like Dr. Bhargav, Dr. Lalji Singh did it. They have come up with a beautiful thing that even the person who has no symptoms has higher viral load than people who are getting into the ICUs. So perhaps the virus is not the answer.
Right.
And if you ask your nephrology people, that those who did not remove the immunosuppressant listening to the West have done much better. You can ask this to the doctors who are caring for the mother and the child, those who did not separate the mother and the child. Both the mother and the child did very well. They got COVID, but so what? Are we trying to prevent COVID, or are we trying to prevent the symptoms of COVID? Are we trying to prevent the deaths of COVID? That is the main question.
Absolutely, I fully agree with you. Thank you, Dr. Arun Singh. I'll certainly get in touch with you. Okay.
Ji sir, ji sir.
Thank you. Wonderful having you. Thank you. Thank you, Venkateshwara Garu, Justice Narayan Garu, Dr. Venkatramana, and all other friends. Krishna Garu.
Thank you.
Thank you.
Good night.
Good night.